Before I get off this slide, let me point out that if you want to reach out to me later after this presentation, if you think of a question that didn't get brought up at this meeting, or just want to talk about stuff Medicare or Medicaid or healthcare benefits, easiest way to reach me is my email address. There's that. And the program's telephone number. There's that. And also, you can visit our website, which basically is if you Google phbsp.org, right up at the top of the list is going to be our program. And that PHBSP stands for, as Drew pointed out, Pennsylvania Healthcare Benefit Solutions Program. So this is the second part of a general review of the Medicare system. Now, this is not going to make you guys experts in Medicare. It's at best going to introduce you to the concept if you're not already at least basically familiar, and it's going to certainly review the salient points of the Medicare system. Presumably, you're attending this because you have a personal interest in how the Medicare system functions. That it's going to be imperative right now or soon down the road that you have at least some grasp of how Medicare works and how you can make good decisions in accessing healthcare through this system. And this is what this point of the presentation is. The first one was understanding how one initially enters the Medicare system by picking up the government portion of Medicare Part A and Part B, what that enrollment process looks like, when it happens, how it happens. But that's the easy part. The hard stuff is what's coming now in these 2 hours. And let me also start by saying it didn't have to be like this. Some things are inherently hard. Trigonometry is hard. Quantum physics is hard. No matter how we try to make it easy, no matter how much effort Stephen Hawkins put into it, it's still hard. But healthcare coverage doesn't have to be hard. It is. It really is. It is overwhelming for most individuals, even well-educated, experienced individuals find trying to navigate through the healthcare system of benefits and insurance coverage absolutely daunting. And they often abrogate taking responsibility for that to whoever purports to say, oh, we're going to help. And unfortunately, that often means putting themselves in the hands of brokers and in the hands of insurance companies, who unfortunately are probably the wrongest people to absolutely put your trust in. For years, decades, I made a living cleaning up the messes wrought by individuals at the mercy of insurance companies and their broker representatives that through either maliciousness, intent, or just stupidity on the part of the individual seeking to help them, caused the beneficiary customer to make bad decisions. And unfortunately, trying to master this is difficult. And unfortunately, for lots of people, they're absolutely at a loss. They're trying to figure out what to do. And this is why our program was created a few years ago in anticipation that individuals are going to be looking for an objective, unbiased, and unbased on trying to sell people stuff. Our entity is made up of lawyers and teachers and social workers, and not one of us is a broker. The point is to help you understand what's out there and help you make decisions by enlightening and educating you. And this is the reason that I'm doing this today. So we're going to look at private insurance products that exist under the umbrella of the Medicare coverage. What they are, what they do, how they work, how they integrate within the Medicare system and with each other, and how to judge them based on the merits of not what they are inherently, but what they are going to do to fulfill your personal priorities for coverage. There is no single product that fits everybody, no single type of product that fits everybody's need or desire. First step is always figuring out what your priorities are. And to say, well, I want something that is cheap and covers everything. Well, that's a holy grail you're not going to get to. What's more realistic is understanding what these products do and how they work, and what are their strong suits and weak suits, and deciding which type of product looks best. Not the specific product from a specific company, but start with just the idea of what these products look like in their general function. So that's the premise for today's discussion. And it's based on also the idea, if you tuned in last week, that Medicare started with a premise that it would be comprehensive enough, that basic Medicare's platform, Part A and Part B, the government portion of Medicare, would be sufficient. It was imagined back in the 1960s and even into the 1970s that if an individual enrolled just in Medicare Part A and Part B, that would be enough, that they would cover enough of the cost that what was left over would be small enough that most individuals would be able to pay that cost sharing out of their pocket. So cost sharing's always been built into Medicare. It was intentionally built in, but it was not intended that it would be such a onerous burden for most individuals. They couldn't meet out of their own pocket the deductibles or co-payments or co-insurance that basic Medicare, Part A and Part B, imposed. Within a decade, certainly within 2 decades after Medicare's creation, the real dollar cost of that cost sharing became impossible for most individuals to handle. As a percentage, usually about 20% in the early days of Medicare, that was absorbable by most individuals' household incomes. By the late 70s, early 80s, 20% in terms of what that meant in real dollars to an individual was unattainable by most individuals. And that opened the door to a significant decision. And the decision was, shall we increase the percentage that Medicare, as in Part A and Part B, offered to the individuals, taking it up from 80% to 90, 95, or even 100%. It was doable. It was a conceivable option, but we didn't choose that. We chose instead, well, we didn't collectively choose. It was chosen by those people in power at that time in the federal government to instead encourage, entice, invite, subsidize private insurance companies to come into and aggressively take on more and more of the responsibility of that coverage. It didn't start that way. It was supposed to be Medicare itself, Part A and Part B, doing the exclusive job. There was always some private insurance that was on the fringe picking up that small balance, but the costs and the functionality in the first decade or so was fairly basic and fairly attainable. We're talking not much more than $10 or $15 a month, and usually so optional that most people said, it's not necessary. Now it is not just optional, it's essential. People are going to be turning to private insurance to work in tandem with the Medicare Part A and Part B platform. And this is where the problem arises, because there is so much stuff out there offered by private companies. And each piece of stuff is somewhat different. Now, there's categorizations of it, and that's what we're going to be seeking, to organize the stuff that's out there into categories that have certain common traits and characteristics. But keep in mind, the tendency for this stuff is to be more different than alike, and it's looking for those common characteristics and understand how they function. So we're going to be looking at private insurance as the enhancement to basic Medicare and how that's going to affect the decisions you make and the utilization of that insurance. So let's start by categorizing any kind of private insurance that you're going to get to go along with Medicare Part A and Part B as to fitting essentially into one of three columns. So the private insurance that you might get could be provided by a former employer of yours. You could have worked for a school district or the state government or the federal government or a private employer that through union negotiation or just maybe possible that the employer was just imbued with a sense of the value of offering this as a post-employment benefit to entice people to come and work for them. Whatever the reason, some of the vestiges of certain types of employment have the opportunity for individuals to use a post-employment retirement health benefit that works in tandem with Medicare. Now, the retiring employee doesn't have to necessarily utilize that product, but it's certainly a consideration, and often the products are good, if not always superior to what else can be gotten, but it's certainly worth being considered. Second category, some individuals are economically distressed enough that they're eligible for a other kind of government benefit called Medicaid. For those individuals, Medicaid acts as an enhancement to the basic Medicare Parts A and B. Some individuals who wouldn't imagine themselves being economically distressed to the point that they would be eligible for Medicaid find that as they get older and the needs for personal care services, either in their home or going into institutional long-term care facilities, compels them to spend so much money that they don't have access to. They must rely on the state to step in to help them pay for the personal care of being taken care of at home or in institution. And that program is Medicaid. So many individuals are in Medicaid not because they're so economically distressed from the beginning, but as they reach a point where they cannot afford to pay for the services necessary, and the state has promised that they would step in and pay, but for sacrificing to a large degree much of the wealth of that family individual, Medicaid operates not just to pay for the personal care in a long-term care institution or at home through what Pennsylvania calls its waiver program. That also entitles the individual to Medicaid paying for, as a supplement to Medicare A and B, the cost of their actual health care benefits. So many individuals who couldn't have imagined that they would be using Medicaid find that in their later years, Medicaid is the lifeline, which is not only going to give them access to home care or institutional care, but also pay for their health care and their prescription medications. But by and large, the largest percentage of individuals that are in the Medicare system rely on their own acumen to go into the market and purchase private insurance to go along with their Medicare Part A and Part B. They're not going to work for an employer that offers a post-employment benefit. They're not, at least at that point in time, eligible for Medicaid. So they're essentially relying on their own shopping skills and hoping they find someone that's going to navigate them well into the system. And this is really where we're going to focus. But the truth is, any one of these three columns is going to have, as the products they're providing, one of the three following categories. So in any one of these three columns, these are the products that you're going to be looking at. So in private purchase or an employer or through the Medicaid system, there's going to be those products which supplement Medicare Part A and Part B. An individual in this case utilizes Medicare A and B as their primary coverage, and then supplements that A and B coverage with an insurance product often referred to as a Medigap or Medicare supplement, whatever the terminology. If that product is a supplement to Part A and Part B, if Part A and Part B are your primary coverage, and it fits into this category. The second categorization is products which effectively replace Medicare A and B. These are the products probably most people are familiar with. Doesn't mean they're the best, just means they're the ones that are most prolific in our system. These are the HMO products, Health Maintenance Organization products, or PPO products, Preferred Provider Organization products. These are the products that usually the employer is going to select as the means by which, while you're working, you're going to have employer-provided coverage. These are also the products that tend to be selected as the means by which retirement products operate. And these are the products that are most hawked out in the marketplace, not because they're the best, but because they make the insurance companies the most money by selling these things. If you enroll in an HMO or a PPO product referred to officially in Medicare as a Part C plan or an Advantage plan, you still have to have Medicare Part A and Part B. You still have to enroll in it. You still have to pay the premiums for it, but you don't get to use it essentially at all. As long as you have an HMO or PPO, theoretically for the rest of your life, you will never benefit from Part A and Part B. You will use exclusively the HMO or PPO to cover. Even though you're paying to be enrolled in A and B, put them in a drawer, take them out occasionally and take a look at them, but don't expect to use them. And for the best or worst characteristics of that product you have, an HMO or PPO, that's what you've embraced. Whether you're using a supplement to enhance Medicare A and B as your primary coverage, or replacing Medicare A and B with an HMO or PPO Advantage plan, you're also likely going to get prescription drug coverage, Part D. So it's either going to be a supplement and Part D or an Advantage plan with Part D attached to it. 1 and 3 or 2 and 3. You can't have 1 and 2. It's either this one or that one. So we're going to take a look at these three in a little bit more detail, starting with Medigaps. Again, Medigaps are supplements to Medicare A and B. They might go under some different terminology if they're offered, let's say, as an employer benefit, or if they're offered in some other marketing process. But by and large, you're going to see this terminology, Medigaps, used. And the characteristic of Medigap is they're private insurance products that supplement Medicare Part A and Part B. Now, in most states, Pennsylvania included, the coverage of these Medigaps are standardized. By that I mean products that are offered that are Medigaps, supplements, are identified alphabetically. There's an A-level Medigap, a B-level Medigap, a C, a D, and I can keep going all the way to the letter N. Each of these products is different from the other, but every company that sells, for example, an F-level Medigap must offer exactly the same coverage that every other company offers. So the Highmark F-level Medigap is identical to Aetna's F-level Medigap, which is identical to Cigna's F-level Medigap. The only difference, the premium costs, and the discounts that the companies can offer based on whatever circumstances they choose. Each category is going to define what must be covered, and each company must absolutely adhere to that and not change the product at any time. And this gives you an example of what the expectation of each alpha level of Medigap will do. Where you see the largest number of check marks in that column represents the most comprehensive level of product. So, for example, the A level type Medigap, which is good, but it's not quite as good as the B level or the C level, and the most comprehensive is the F level. An F level Medigap, in tandem with Medicare Part A and Part B, guarantee the entire cost of healthcare, whether it's inpatient or outpatient, is fully paid for by that combination of Medicare A for inpatient, Medicare Part B for outpatient, and the supplement F that covers. Doesn't mean that everybody seeks the F, and it doesn't mean the F is absolutely the only product. There are these other levels which don't quite cover as much as the F level, but cover a significant part. And obviously, if they're covering slightly less, sharing more responsibility with the individual, and their premiums are a bit cheaper. But if you're looking for the core area where the best coverage lies, it's somewhere in that neighborhood of F and G, kind of C and D, far less with A and B, and far less for K, L, M, and N. Does it mean they're not the ones you should consider? It just means it's less coverage with a lesser premium. Also, starting in 2020, a couple years ago, two of the products were eliminated for people that reached 65 after 2019. Another way to say it is if they were born after 1954, they do not have access to the F level or the C level Medigaps. Not because the F or the C level Medigaps were so bad or so unpopular. Again, two of the most comprehensive products that represent Medigaps are the F and the C. And together, those two product lines represented over 85%, in fact, most years over 90% of the Medigap products that were in play at that particular time. These were the core ideal products that people sought. So eliminating them was not to get rid of something that didn't work or something that nobody wanted. No, it was quite the opposite intention. And that intention is reflective of an ongoing conflict with Medicare as it currently exists. Sometime around the 1990s, there was a strong desire on the part of federal government to try to get out of the direct responsibility of covering people's healthcare costs. It started in the 1980s. It picked up far more momentum in the 90s, and by the time we got into the 21st century, it was a thing. And it isn't a Republican thing or a Democrat thing, it's a government thing, it's a purple thing. It's the desire of government, whoever's running the government at that time, to abrogate the responsibility of saying, we'll pay, don't worry about it. And yeah, if you get a supplement, we're still going to pick up 80 or 90, or in some cases, all of the percentage of the cost. That's why we were created. There was a desire to get out of it, to hand it over to private insurance as much as possible. And from the standpoint of the federal government, in the hands of those individuals that did not believe government should have that responsibility, that it wouldn't do as good of a job, they find that too many people are actually pretty happy with a combination of Medicare A and B and an F level Medigap or a C level Medigap. They liked the idea that whatever the cost of the services they would have, it was fully paid for. And so the termination of the access to F and C was to actually terminate the most desired and most effective products that put the burden on the government to pick up their share. And hoping it didn't quite work out that way back when this was initiated. But it was hoping that this would be simply the first step in the total elimination, or at least the significant defanging of Medigaps, so that the only thing that would be left was an alternative to people using HMOs and PPOs. That is the desire right now, to shift individuals away from relying on Medicare A and B as primary and shift those individuals in relying exclusively on HMOs and PPOs. There's nothing inherently wrong with selecting an HMO or PPO as long as you understand its limitations and how it works, but it would also be nice to have other options. So there was a pushback when it was realized that this was a declared war on the Medigap system, and that if allowed to continue over the years in which the previous administration was in charge, we would have seen a significant gutting of the Medicare option. What we're left with is, if you were born after 1954 and you're not by then already in the Medicare system, you're going to be denied access to purchasing the F or the C level Medigaps. You can still pick any of the other columns, but unfortunately, the two best, or at least the two most comprehensive, are now precluded. The G is still pretty good. It's not quite as good as the F. It's still better in terms of its coverage and more comprehensive than the other Medigap levels. And it's certainly more comprehensive than any HMO or PPO in terms of its coverage. Now, there's something else you should know. If you select this methodology of coverage to use Part A and Part B as your primary coverage and pick up a Medigap to enhance it, whatever level is still available to you, you have a limited time to make this decision. From the point that you've enrolled in Medicare, more specifically, from the point that you've enrolled in Medicare Part B. So, I got my Part A back when I turned 65, but I didn't pick up Part B because I'm still working. All right. So this is not going to apply yet. Once you finally enrolled in the Part B portion of Medicare, a 6-month clock starts ticking. In those 6 months, you could go to any company selling a Medigap and say, I want to buy whatever level of Medigap you're selling and that I'm still entitled to purchase. Once those 6 months are up, for the rest of your life, the only way you'll be able to purchase any level of Medigap that you're still entitled to is by going through underwriting. And in this underwriting process, an insurance company has the power to decide whether they want to sell you a Medigap product or not. So even if you go and say, yeah, I know I can't get the F or the C, but I want the G. And they'll say, well, when did you go into Medicare? It's a couple years ago. Whoa, we don't have to sell it to you, but we'll consider it after we put you through underwriting, after we decide whether it's in our economic interest to sell you that product. Because once we do, we can't undo it. Once we sell it to you, the only way it ever goes away is if you, the customer, don't want it anymore. Quite honestly, you look like a pretty big risk to us. Now, for the first 6 months, it doesn't matter how sick you are. It doesn't matter how old you are. It doesn't matter how anything you are. If you've got Medicare Part A and Part B, if you want a level of Medigap, you can still purchase. If that company is selling it, they have to sell it to you. After 6 months are up, they don't. Ever. for the rest of your life. There are some times beyond that 6 month that you can still have access to Medigaps. Some states, Pennsylvania is not one of them, is more generous about accessing Medigaps and say, no, there's no guarantee accessibility based on an underwriting process. There's a constant open enrollment access, but Pennsylvania is not one of them. In fact, there's only 2 or 3 states that are that. Most likely, the way you're going to access a Medigap after your 6 months is by experiencing a triggering event. And the easiest way to describe a triggering event is something happened through no fault of your own that has eliminated your current coverage. For example, you have an HMO or a PPO and the company went out of business, or the company discontinued the product line, or you moved out of the area and that product doesn't follow you to California. Or through no fault of your own, the company simply went out of business. Or through no fault of your own, the product was terminated by Medicare saying the company's a bad actor. In that case, if through no fault of your own, oh, and by the way, another one is I was using my employer's retirement benefit and it's going away or it's not working effectively. It's not my choice. It's my employer who's deciding to terminate the retirement benefit or scale down the retirement benefit. If effectively through no fault of your own, the nature of your coverage significantly changes, within 63 days of that change going into effect, you have the ability to go to a company selling Medigaps and say, hey, a triggering event occurred. I can prove it. I can show you the information. And within the context of that triggering event, within 63 days, essentially 2 months after the occurrence of the triggering event, I want to purchase a Medigap. These are the levels I can purchase. You have to sell it to me if I demonstrate to you the triggering event occurred, and you cannot put me through underwriting. But here's the thing. There's no guarantee you're going to have those triggering events. There's no guarantee also when finally you realize you probably should have got a Medigap because now the cost of your healthcare are significant, or the needs for your healthcare services have increased so significantly because of your catastrophic and economically exacerbating situation, diagnosed with cancer or progressive deterioration of your organs, the need for aggressive intervention for condition that puts you in hospital more frequently than not, that requires high-end diagnostics and high-end constant levels of care, like kidney dialysis. And wow, the co-payments are killing me on my HMO or PPO. I should have got a Medigap. Too late. Without that triggering event, going to an insurance company and say, I'd really like to get as good of a Medigap as I can. They're going to say, and we really aren't going to do it because you're really going to cost us too much money. So deciding whether to get a Medigap or not and deciding which Medigap to get is a big, hard decision, usually made at the beginning of your entry into Medicare and usually staying true to that pretty much for the rest of your life. So this is some examples of the triggering events. You can take a look at this later on to see if, well, possibly one of these might fit me, but also insurance companies in the initial years after you've entered Medicare, when you still haven't manifested major healthcare issues. Some insurance companies may be a little bit more lenient, a little bit more generous, but as time ticks by, as you get older, and certainly as your healthcare circumstances manifest a more risk of cost to the insurance company, they are far less likely to be accessible. Medigaps, whether you purchase them initially when you enter Medicare or you're allowed to get them later, by making through a triggering event or passing through underwriting are going to be priced one of three ways. You can anticipate, not very likely, that the insurance company is going to have a fixed premium for all of their products for all individuals, no matter how old they are or sick they are. That's called community rating. That certainly is the case with HMOs and PPOs. Doesn't matter how old you are, how sick you are, how whatever you are, that particular HMO has a fixed premium. It's the same premium for everyone for that particular year. Will it go up? Probably. But for that year, if you want that product, that's the premium. Medigaps usually don't work that way. In fact, almost invariably don't work that way. They work either by assigning a premium based on how old you are when you enter the Medigap product. That's called an issue age. And some companies, some brokers of some companies will fib. It's not a fib in the sense of it's written in the product and it's purported to be a valid promise, but it's not really a promise that'll ever be fulfilled. And the promise they'll make based on issue age will never, ever, 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 ever increase your premium. Oh, if that was Pinocchio. They can promise that within the context of their marketing, but they work around it by also building into the Medigap contract a stipulation that they also have the right to increase the premium at any time based on inflation, based on the increased cost of healthcare, just based on whatever whim they feel like. So realistically, a promise that based on issue age, based on fixing the premium at a certain point, is simply to define at this age, this is what your premium is going to be. Will it go up? Most likely. How much? No one knows. The other way is attained age. And this is more of a fair disclosure of information. And honestly, attained age, issue age, it's the same thing. Issue age says, this is the premium as you start. Will it go up? Don't believe anything other than yes, it will. How much? We don't know. When? We don't know. It depends. Attained age, at least, is straightforward. It's going up. When? Every year. By how much? We're going to tell you exactly. Oh, so I know exactly what it's going to be every year for the rest of my life. No, that's also a bit of a fib. So the attained age means every year, every time you attain your new age, either each year or each sequential, it's going to go up a certain percentage, 2%, 3%, 5%, whatever it says. So I know it's going to go up 2, 3, 4, 5. Yep. And that's it. Nope. Because also they build into the contract that they can also increase the premium in addition to the fixed 1, 2, 3, 5, whatever percent they stipulate. They can also increase it at their whim based on inflation and the cost of healthcare and just whatever they feel like that the market will bear. So at least attained age tells you, here's what to absolutely expect. There's going to be a percentage increase every year. But that's not necessarily the only percentage. Issue age says, we're not going to absolutely increase it every year, but we're also not going to fulfill the promise implied that once we fix this based on when you enter, it'll never go up. Medigap policies, like everything, are going to have price increases. Sometimes it's clearly spelled out. Sometimes it's not, but there will be increases. Now, the good news is, whether attained age or issue age, the products over the last decade or so have gone up minimally. That's mostly because inflation has been minimal. And the cost of healthcare, defined under the Medicare system, has also been minimally increasing. Again, because inflation has minimally increased. As a result, a typical increase from a Medigap policy from one year to another is usually in the range of about 3 to 5%. I can't promise it's going to stay that way, especially in light of inflation and the change of circumstances. We're still seeing in this last year about a 3 to 5%, although certain companies are inching closer to 7%. Next year, we're going to see whether they stay true to that single-digit increase or whether we're going to see it bleeding into the double digits. But for right now, expect that there will be increases from year to year and expect that they're going to be relatively lower, at least compared to what HMO and PPO prices and cost sharing can be. And that premium cost that you're looking at, that initial point when you're pricing Medigaps is going to depend on your age, again, unless they purport to be community rated. It's also where you live. That's less imperative as it used to be a few decades ago, whereas the cost of healthcare has kind of flatlined in all areas. It used to be the more urban, the more costly healthcare was as opposed to rural. That's a misnomer. So pretty much whatever your zip code is, whatever region you live, the premium cost for that Medigap product is going to be pretty much identical because the cost of care is going to be pretty identical. Certainly, it's going to be dependent on the company selling the product and how much they want to charge and what they think the market will bear. But there's something else that Medigaps can do that HMOs and PPOs are forbidden to do under the Medicare umbrella. Medigaps can offer discounts, all sorts of discounts. They can discount your gender. Females usually get a better deal than men. They can discount you if you're a non-smoker. More to the point, non-tobacco user. So take into account not just smoking the traditional cigarettes and cigars, but vaping and using snuff and whatever else. If you can demonstrate that over the past couple of years you are a non-user of tobacco, then significant discounts. Also just married couples or family discounts. Not that the product covers two people or more than that. No, it's that two individuals in the same household are buying from the same company, and often discounts as much as 10 or 15% for those products can be offered. And certainly individuals attempting to get a Medigap product by going through underwriting are now exposed to a much higher premium or potentially a much higher premium. So Medigaps are going to vary from company to company, from product level to product level, and for various reasons. And it becomes necessary to do some more aggressive shopping. Look to see who's offering the best deals, what levels are going to represent the best cost effect if you're inclined to want to go with the Medigap. Medicare Advantage plans tend to be more guaranteed for that year's premium, but are certainly not guaranteed for the level of coverage or the expected continuation of coverage in the future. So Medicare Part C plans are the HMOs, the PPOs, they're managed care. And they are an alternative to Medicare Part A and Part B. They're still under the Medicare system. They're regulated by Medicare. But their coverage is absolutely entirely provided by private insurance companies, and they replace Medicare A and B's application. And the reason Medicare as a government entity is so inclined to support the utilization of these is because once the individual has enrolled in in an Advantage plan, a Part C plan, Medicare Part A and Part B are no longer responsible for that individual. At least as long as the individual has an Advantage plan, Medicare A and B do not have to shell out for the cost. And so, back a few decades ago, it was realized that Medicare could be more cost effective as an entity if instead of directly paying an 80 or so percent of the cost sharing of an individual's health care, they would instead subsidize private insurance companies to take on that responsibility. So the reason HMOs and PPOs are so aggressively marketed is because those companies that are marketing them are going to get subsidized by the Medicare system to the tune of somewhere between $1,000 to $1,500 a month for enrolling that individual. And from Medicare's position, that's money well spent. There is a predictability. We know exactly how much we're shelling out. If we could get everybody in Medicare to take one of these, we would have a pretty good idea of how much we have to spend because we're subsidizing the companies rather than directly covering, and thus making it more predictable. From the insurance company standpoint, they're thrilled to get this kind of windfall for aggressively swaying individuals away from using Medicare A and B directly. They make a lot of money through the subsidization. Billions of dollars per company, or else they wouldn't do it. And there's a secondary windfall for this. A supplement, a Medigap, cannot deny an individual coverage of service. If the individual goes to a doctor or a hospital and says, "Do you guys take Medicare?" "Sure we do. Here's my Medicare card." And the doctor or the hospital says, "Well, how are you going to pay for the balance?" "Here's my Medigap card." It's all paid for. And the Medigap company can't say, whoa, wait. You've been in the hospital too long. You've gotten too many diagnostics. You've seen too many doctors. That's exclusively the realm of accepting or denying that belongs to Medicare itself, Part A and Part B, the government's wing of healthcare coverage. A supplement, if Medicare says, yeah, this is a covered service. Yes, these length of stays in the hospital are perfectly acceptable. And the supplement pays the balance and has a smile on their face and say, oh, okay. An HMO or PPO is in total control of the process. They dictate the networks where you can go to get served. They dictate the levels of care you get. And when that HMO or PPO entity also owns the facilities you go to, when the insurance company owns the means of service, or the means of service also owns insurance, I can think of a couple examples, then not only are they dictating where you go, what you get, but they're also imposing that on the providers themselves. You want to keep your job? There is a case review that is determining whether this individual stays in hospital for another few days or gets the following services, or whether this thing is within range of, is it going to be cost effective? No. Often doctors don't get the say in whether an individual gets access to the kinds of services that the patient wishes they could have. When the insurance company is saying, sorry about that, not cost effective, thus denial of service, thus termination of stays in hospital. Statistically, this happens way more often with individuals with HMOs or PPOs than it does with individuals with Medicare A and B relying on a Medigap. And this is certainly a value for the insurance companies offering this product. Now, one of the things that Advantage plans offer that are very enticing to individuals that are relatively healthy when they go into Medicare, that see the inherent value of a lower premium rather than a guarantee of more comprehensive coverage, because they don't see the need for this initially. They may see the doctor once or twice a year just for a basic checkup and some simple diagnostics. Why would they want to pay the cost of a Medigap when they can get an HMO or PPO for really cheap? And really cheap could be zero. Why zero? Because remember that insurance company offering a zero-level HMO or PPO is getting subsidized $1,500 a month. That's where their real income is coming from the subsidization. Very, very often, HMOs and PPOs are offered in the marketplace well under $100 a month, whereas Medigaps typically cost about $100 to $150 a month initially for individuals enrolling. So an individual who is relatively healthy, very healthy, will say, look, I can save myself $1,200, $1,500, maybe $2,000 a year in not getting a Medigap, and instead getting a zero premium HMO. And honestly, it works quite fine for what I need. The co-payments to see a doctor for a simple checkup are minimal. And the basic diagnostics, maybe some blood work, maybe an x-ray, minimal. And I know when I get into the high stratosphere of the really high-end services, I know the co-payments are going to be devastating, but they're not happening to me. And I don't see the future the same way as other people are worried about it. I'm thinking of the immediacy. I'm thinking of what I'm saving. And you know what else I like about these Advantage plans? I like the swag that they're offering. I like the fact that because they're kind of outside the standard of Medicare Part A and Part B. Yeah, I know they're under the Medicare umbrella, and Medicare encourages them to offer other kinds of things that Medicare themselves don't cover, like basic dental, basic vision, health club memberships, wellness programs, all sorts of cool stuff. An HMO or PPO could say, you know what? We'll offer you a taxi service, a transportation benefit that'll take you wherever you want to go. We'll offer all sorts of things that step outside the range of what we would consider normal medical coverage. We'll send a concierge over to your house to help you sort through your life. We'll do whatever it takes to get you to pick our product. Because we know at the other end of that, we're going to pick up $1,500 from the feds. And the medical part of it isn't that great, well, relative to what a Medigap could be, but for you, it might be okay. And maybe the thing that you really want is all this other stuff. It's not really medical, but it's cool. And some people want health club memberships more than, or dental access more than the other stuff. Now, keep in mind a few things. These things are added on. And generally, the value is far less than what it appears to be. Oh, but I get dental. There are limits on the dental service you get. Yes, it's somewhat, but it's certainly not comprehensive. And your access to other kinds of services often come with cost sharing. When they send a car over to take you to your doctor's visit, it's a $40 or $50 copay. Or the concierge doesn't come over for free, or the person that helps you out isn't necessarily for free either. And just because they offer it now doesn't mean they'll offer it down the road, or just because it's offered doesn't mean it's unlimited. This is about generating a profit for the company. And as long as it can work within that context, then it can be acceptable. And you've got to go into it with eyes wide open about the limitations and later down the road what that could mean. And if that's not important, then that's not important. But you at least have to be aware of the value of this product against the limitations of this product. And if you understand that, going in with eyes wide open. Understand also that a Part C plan is going to be very inherently different from any other Buddy's Part C plan. Even within the same companies, there are going to be 5 or 6 possible selections, and they're going to be slightly different from one another. They're going to be different in premium costs, co-payments, and the services they offer. And this massive breadth and depth of products overwhelm people. I don't know which one to pick. Oh, please won't someone help me? Oh, please won't somebody from the insurance company make a decision for me? I don't know how to approach doing this. At least with Medigaps, there's kind of a logic to it. there's a certain category, and each category guarantees a certain level of coverage. And what I'm really shopping for is who's offering the best deal within the category. They're all over the place. And coming with some kind of logic or structure to that choice is fairly daunting. Now, there's ways to approach it. I'm going to do a presentation later in the year on how to approach going shopping for products, especially for Part C products. But for the person who's just, I think I want to do this kind of thing, good luck on how you're going to select it and how you're going to value it. The other thing with Advantage plans, unlike Medigaps, which essentially are a once-in-a-lifetime selection, staying loyal to it for after you purchase it forever. You can leave it, but there's not a good likelihood you'll ever be able to get another one or go back in. Advantage plans are the opposite. Every year, there's an enrollment season, October, November, early December, and in every year, you get to evaluate the HMO or PPO that you have, keep it for the next year, or give it up and get another HMO or PPO. Can I go to a Medigap? You can't pass through underwriting? No. If you can pass through underwriting, possibly. But statistically, most people that select going with an HMO or PPO track at the beginning of entry into Medicare, a significant percentage are going to stay loyal to that for all sorts of reasons. And ultimately, when they finally see they probably should have gotten more comprehensive coverage, it's a little too late to go with the Medigap. Well, can I get a better HMO or PPO? Not really. But if I spend more money, not really. But there's the zero product, and then there's ones for $200 or $300 a month. Aren't they inherently that much better? No, not really. They're just that more expensive. The strong suit of the Advantage plan, the HMO or PPO, this is important. Listen up. The strong suit is in their low premium. Spending more and more in premium does not give you a significantly better Advantage plan. They're just more expensive. Why are they offered? Because they know people will believe if I spend more, I must be getting more. And the truth is they're not getting that much more to generate the increased cost of their premium. The most effective utilization of an HMO or a PPO is getting a significantly reduced premium amount, as close to zero as possible, and utilizing it with its intent of sparingly covering the services. Getting a far more expensive HMO or PPO does not increase the levels of coverage that much to justify the premium difference, and usually leaves the individual frustrated when they're faced with an incredibly expensive service. But they can certainly evaluate the product each year. There's the initial entry, and then each year thereafter. And with special circumstances, they get to change from product to product at least once a year. The third category of product, the Medicare Part D, is the newest kid on the block. Those products came about just at the beginning of the 21st century, 2006 specifically. And that product has become probably, for most individuals, the most important consideration of coverage. Now, I'm going to generally talk about Part Ds, but later on this year with AmeriServe, I'm going to be doing a focused 2-hour presentation just about Part D coverage and about, honestly, the failings of Part D. As effective as one can put together a strategy of coverage for inpatient and outpatient services, as comprehensive as they can make it by getting Medicare A and B and using an F-level Medigap if they can get it, or G-level Medigap even. There is no way a person can buy a good Part D plan that is going to be as comprehensive for their prescription medication coverage as they can for their in and outpatient medical coverage. Part Ds are the weak link of the system. Part Ds are going to impose on the individuals, no matter how much the premiums they pay, a significant cost sharing. And there's no holy grail that if you just look hard enough, you'll find the product that significantly covers the cost of your drugs. This is the hard part. And unfortunately, what makes it even harder is that unlike inpatient care and outpatient care, which is perhaps constant but not daily, prescription medications are often a daily regimen. You don't go to hospital every day of the week, every week of the year. You don't even go in to see your doctor that frequently, or get diagnostics that frequently, or therapies that frequently. Quite often, you're taking not just one, but many medications every day, presumably for the rest of your life. And as you get older, that number of medications increases. The average number of prescription medications taken by an individual at 65 years is 6. Well, I'm not taking that many. That means someone else is taking more, possibly a lot more. And by the time you reach your mid-70s, that number has almost reached a dozen medications every day that you're taking. And many of those medications are minimally expensed because they're generic and the retail cost is low. But many of the medications are not measured in terms of hundreds of dollars or even thousands, but tens of thousands of dollars for a monthly supply of those medications. So Part D, as I said, has been around now for about 17 years. It's voluntary. You don't have to get Part D, but most people do. It's available either as part of getting your Medicare Part A, Part B, and a Medigap. You'll also pick up a standalone Part D plan, or it can be incorporated into your HMO or PPO as incorporated Part D coverage. Whatever the case, certainly private insurance products regulated by the Medicare system. And if you don't pick up a Medicare Part D product, you could be penalized later for not having picked one up. So it's voluntary, but it's highly incentivized, as in if you don't get one of those, later when you try to get one of those, you'll be penalized a significant percentage for not having enrolled in one. Now, the good news is if you go with an HMO or PPO, then most likely a Part D product has been rolled into the HMO or PPO, one less thing you have to worry about. And if for individuals that are getting Medicare A and B and a Medigap, one can get a basic Part D product for less than $10. So currently the premiums, not for every Part D plan, but for the more basic level of prescription coverage for those individuals that say, I'm not taking any meds, or all my meds are generic, and or I go to the VA to get my meds. Why do I need to get a Part D plan just to avoid being penalized? And the market said, okay, if this is the case and you're really just doing this to not be penalized down the road for not having one, okay, here's the deal. We sell products that for certainly are less than $20, some of them less than $10. And even for those generics that you would get, we'll cut you a break and knock off even the cost sharing, so that those generics are coming to you at zero cost. So I find that most individuals that are reluctant to want to get a Part D because they really don't need one gravitate towards this boutique kind of product, a less than $10 Part D plan that says, look, if you're taking generics, your generics will cover whatever the $2 or $3 cost share is, so you get them for free. And more importantly, you've avoided later being penalized for not having Part D coverage. Like I said, there's two formats. Most of the time that you get an HMO or PPO, it's rolled into it. For individuals that are getting Medigaps, you're gonna likely go shopping for an independent one. Part D plans, even if you have a Medigap as your supplement, Part D plans, you're going to evaluate from year to year. Initially, when you enter, you're going to make your first selection, and then each year thereafter, in October, November, early December, you're going to see whether that Part D plan is still working with the drugs you're currently taking, whether to upgrade or downsize the coverage. And every year, like with an Advantage plan, you get to decide whether to leave the one you have in place and roll over automatically to the next year, or to swap it for a new one. And it goes into effect at the beginning of the year and stays in effect for that year. And like with Advantage plans, there's special situations like moving out of the coverage area or being eligible for certain other kinds of benefits, which opens the door for special enrollments during the course of the year. So Medigaps are generally a one and only time choice. The only alternative choice you're going to make is to completely walk away from Medigaps and go with an HMO or PPO. HMOs and PPOs, if you elect that, are annually changeable. Part D plans are annually changeable. But trying to go from an HMO or PPO to a Medigap and passing through underwriting may be quite difficult and maybe quite more expensive than initially enrolling in the Medigaps at the beginning. Part D plans in operation are going to offer certain prescription medications that they cover. No Part D plan is going to cover every prescription medication that's being available in that particular market. And the drugs that this particular Part D covers is referred to as the plan's formulary. Every plan has a formulary. Every plan is going to define which prescription medications they're going to cover for that year. Now, Medicare imposes that every Part D plan must cover a certain number of drugs and a certain number of drugs in each therapeutic category. After that, it's up to each plan to decide what additional drugs they're going to cover. So there's a certain uniformity, but that's simply a basic uniformity, which may or may not exceed depending on the quality of the product and often depending on the premium that you're paying for. In addition to the drugs that they're covering, the plans also organize the drugs, their formulary, in terms of cost sharing. And usually the cost sharing represents at least 4, sometimes 5 or 6 levels of coverage. They're called tiers. So each Part D plan has a tier for cost sharing with their generic drugs. Usually the cost sharing is a couple dollars for a 30-day supply. In some cases, even less than that. Some cases, as an incentive to take their product, the cost sharing is as low as $0. The generics are free. Buy the coverage of that plan. The next level might be a non-preferred generic, generics that tend to be more expensive, and the cost sharing will be a little bit more. But certainly every Part D plan has a level where they're covering brand names or non-generic drugs, and usually 2 levels for that coverage at least. There's the preferred brand names and the non-preferred brand name drugs. Preferred doesn't mean they're better. Preferred doesn't mean they're more desirable to the individual. They're preferred because they are less expensive in terms of retail cost and preferable to the insurance company because these are the ones they would rather be covering that you're taking than a non-preferred, which is often far more expensive. And the co-payments for the preferred brand names, the preferred non-generics, usually are in the category of about $30 or $40 for a 30-day supply. The co-payments for their non-preferred lists of drugs are usually getting close to or exceeding hundreds of dollars for a 30-day supply. But that's not even the most expensive category. There's going to be at least one more category in Part D coverage, and that's what's referred to as specialty or compound medication coverage. These drugs are the highest level of coverage, and these represent retail costs that aren't even in the hundreds, but certainly the thousands or even the tens of thousands of dollars for a 30-day supply. The cost sharing is not in terms of dollars, like for generics, $1 or $2, or preferred or non-preferred brand names, 30 or 40 versus 110 or 180. These are broken down into percentages. The percentage that the plan will cover is usually something like 70 to 80% of the cost, maybe even less than that. Certain less expensive premiums might only cover them at 60 or 65%. And the rest of that cost for these specialty drugs are borne out by the beneficiary. They could pay as much as 40%, certainly not much less than 20 or 25%. And if we're talking about prescription medications that are retailing at thousands or tens of thousands of dollars, that percentage can be devastating. Now, there's something else that all the Part D plans have. They have a guaranteed endpoint for their coverage. This was highly fought for by the insurance companies when Part D was being created. On one side of the aisle, there was a desire to have an unlimited continuation of coverage throughout the year. On the other side was to cap that limitation for the entire year. The compromise was to cap it for a period of time, and if the individual beneficiary was able to buy themselves out of this, then the insurance company was back online with a responsibility. And that's what we have applicable to all Part D plans. At the beginning of the year, if the plan has a deductible, the beneficiary has to pay dollar for those drugs until they've met the deductible. There may be some exceptions. Generics might not be subject to the deductible, and some plans might not have a deductible. Once the deductible is met, if there is one, then the plan starts cost sharing with the individual. I'm using 75-25% because that's pretty typical with the split on the cost of the drugs. And it's usually the commonest average cost sharing for Part D plans. The plan will pay 75% of the cost of the medication. The individual beneficiary pays about 25% of the cost of the medication. Until the purchase of the drugs at some point in the year, not just what you pay, but you and the insurance company pay, so the retail cost of the drug. When that reaches that certain amount, for 2022, that certain amount is $4,430. When you and the insurance company have spent $4,430, you've reached what's called the initial coverage limit. All Part D plans have the same initial coverage limit for this year. When you hit that, combining what the insurance pays, what you pay, you're in the coverage gap. The coverage gap, also referred to as the donut hole, is that point where the insurance company drops off. They don't pay any longer any of the cost of your medications. In the bad old days, up to about 2011, 2012, that meant the beneficiary paid the entire cost of their medications until they reached the other end of the donut hole, the out-of-pocket limit. So between this and this, the individual beneficiary was on the hook for the entire cost of the medication. Now, if they managed to reach that number, they were in what was called catastrophic coverage for the rest of the year. The insurance company came back online paying 95%. The beneficiary now only paid 5%. But it meant they had to get from this number to that number completely on their own. And often, in the early utilization of Part D plans, individuals could not afford to pay the full cost of their medication, even if it meant getting another $3,000 in. And often, very often, individuals simply stopped taking medication, or at least stopped taking some of their expensive medication or tried to stretch it out over a longer period. The insurance companies were quite aware of this. What's happened in the past decade is the federal government has stepped in. It's politically incentivized to offer some kind of assistance to individuals. And so for the past decade, the federal government has been covering at a larger and larger percentage each year the cost of the drugs while the individuals are in the donut hole. So once the individual goes in the donut hole, by reaching this level, and the insurance company drops off their responsibility, the federal government steps in while the individual is in this coverage gap and pays 75% of the cost of generic and non-generic drugs, and the beneficiary only pays 25%. Kind of similar to what they were paying before they went into the donut hole. Often, the individual currently won't see a huge difference of cost sharing from pre-donut hole to post-donut hole. So, not a guarantee, and not a guarantee they're going to be absolutely essential. But ultimately, it has helped more individuals navigate through this process to get to this final point. And when they're in catastrophic coverage, back online comes the insurance company, and now they're paying a significant part, 95%. But for some individuals that are utilizing drugs that are retailing for thousands or tens of thousands of dollars a month, oral cancer medication or medication for MS or medications for chronic, constant, pernicious conditions, where the cost of those medications are measured in the thousands or tens of thousands, even 5% of the cost share can still represent hundreds or even thousands of dollars on their own, thus putting a significant burden on individuals. The biggest economic crunch for most individuals on a regular basis in the Medicare system is the cost of their medications. The biggest economic crunch in general for individuals in America is accessing the cost of medications. And the weakest part of the Medicare system in terms of guaranteed coverage is the part that covers prescription medications. And it doesn't look like there is a foreseeable change or relief on the horizon. This is likely the norm you're going to be dealing with for some time to come. And in fact, it is getting worse, which I'm going to talk about in a couple months when we look at prescription drug coverage in America in detail over a 2-hour period. There's something else you need to know. That even if the plan purports to cover that medication, it's part of their formulary, even though you know what it's going to cost, and even though you don't want to pay that much, you're prepared to because you need that medication. Your doctor has told you that medication is essential to keeping you healthy, to correcting the problem that you're dealing with. You show up at the pharmacy and you say, here's my prescription. And the pharmacist said, I can't give it to you until I get authorization. Well, isn't that what the whole point of the prescription is? Yeah, I know, but this is authorization that's imposed in addition to the prescription. It's called prior authorization. The insurance company will not cover this drug. Now, you can buy it with the prescription, but you have to pay full price for it. The way to get the insurance company to cover what it promised it will pay is to get the doctor to file an extensive report validating that this drug is an essential drug. Wasn't that the whole point of a doctor saying, here's the prescription? I know, but this is not about the legality of a doctor verifying or the efficacy of a doctor verifying this is the one you should take because I'm a doctor. This is economics. This is the insurance company telling the doctor, if you prescribe this drug, we're going to make you go through a process where you have to argue with us, the insurance company, why that drug is the drug this patient should be taking. You have to be prepared to argue with us that this is the right one. Now, you're going to likely win, but we're going to put you through that obstacle to send a message to you, doc. You prescribe it, you're going to work hard to justify it. And every time, every patient, every month, we're going to put you through the ringer again. Now, there's a drug we'd prefer you prescribe to the patient, a drug much cheaper. It's in the therapeutic category. It's one that we include in our formulary, and it could save us, the insurance company, hundreds or thousands of dollars. You want to insist on the other one? Fine. Be prepared to do a lot of paperwork for every patient. Get the point, doctor? And if you really don't get the point, we'll do it in a different way. We'll put you through step therapy. So the patient shows up and says, this is the drug I'm supposed to take. And the pharmacist says, unless you're prepared to pay for it all, I can't give it to you. And to justify the insurance company paying for it, you got to not only get prior authorization, you got to demonstrate you have tried every other medication in this therapeutic category. Well, those are dozens. Yep. And you have to, but it takes a while for the efficacy to build up. This could take well more than a year if I went through all of them. Yeah, we know. That's the point. And are we really doing this, says the insurance company, to challenge the doctor? No. Not to ultimately say, no, he's going to take a different drug because of prior authorization or the step therapy requirement. No, it's sending a message to the doctors that are in practice, that know the game, know what's going to happen. It's saying, get ready for it. You prescribe certain meds, you're going to have to work hard to justify. You don't want to do that? Figure out how to prescribe the meds we'd prefer you do. This is channeled work activity. This is compelling you to follow the direction we want you to. Now, doctors are aggressively in favor of not submitting to the dictates of the insurance company. But there are limits. And sometimes you're not quite sure whether that drug that's being prescribed is the drug that is the most effective drug, but the drug that's the most effective in that it will pass muster with the insurance company. And it compels the patient to do research on their own, to know what drugs are considered the most effective and often on the more expensive spectrum of the accessible drugs. Is the drug covered by the plan, and is the drug going to be subject to a prior authorization or step therapy requirement? And will the doctor support you on that and go to bat for you and go to battle for you with the insurance company? Some docs do, some docs don't. And this, again, puts more burden on the individual patient to be more invested in their process, to take more ownership of their health care. It's unfortunate, but it is the situation we're in as long as we are dependent on insurance companies to dictate not just how much, but how effectively they're going to cover. Ultimately, whatever choice you're going to make is a personal decision, a personal process. It's about you defining what are important to you. And those priorities are certainly going to change as your life continues. But initially, and at least for that year, you start by asking yourself, what do I want my insurance to accomplish? What are the most important things? And it could be, I want the cheapest thing I can get. All right, that's your priority. And certainly you can fulfill that. But if you don't start by saying, what is it that I want it to do and how can I get there with the most effective? And do not go in with the assumption, I want to get the most coverage at the cheapest price. It's the wrong way to approach. I know it's instinctively what everybody wants to do. I want to get the best I can for as little. It doesn't work that way in this kind of situation. It's listing the things and understanding that the more you list, the more it's going to cost. And if price in terms of coverage is the dictating, driving it means it's sacrificing significant parts of coverage to attain that. And if this is sacrificable because you're not using and you don't expect to use down the road, and the price of the cost of the drug is the most important thing, understand what you're giving up and understanding the limitations of that going in. And that's fine, because that's your choice and how you do it. Ultimately, this is what you're looking at. Ultimately, when you go into the Medicare system, you're making a choice between one of two significant options. This is it. This is the schematic of how Medicare operates. This is what you are looking at in terms of what am I going to do as I enter Medicare, or if you are able to navigate and negotiate into a Medigap, this is potentially something that I can alter. But truly, invariably, for most individuals, this choice is a choice they're going to make at the beginning of entering Medicare, the choice they're likely going to live with throughout their continuation in Medicare. You're going to choose option one, which is to say, I'm enrolling in Medicare A and B, and my Medicare Part A and Medicare Part B is my primary coverage. I'm going to supplement it with a supplement offered by my employer as a true Med Sup, using Medicare A and B as primary, or if I go into the marketplace my own, I'm purchasing a Medigap supplement. Either case, it's secondary. Part A, Part B is the primary coverage. It covers initially the cost, and what's left over is picked up by that supplemental product. The value of that is, if I use Part A and B, I can go to any doctor or hospital or care provider anywhere in America that agrees to accept Medicare A and B. And as I said last week, you have a likelihood that every hospital anywhere in America you're going to go to, because of their licensing requirements, do and must accept Medicare. And every doctor you're likely going to go to for your care is going to accept Medicare A and B. Thus, you have an incredible reach, not just locally, but nationally, for the healthcare system. If there is a place you want to go to because they're on the cutting edge of the therapy you want, very likely they're going to accept Medicare A and B. And if they accept Medicare A and B, by law, they must accept anybody's supplement, no matter what the insurance company is that's selling it. And a good combination of Medicare A, B, and a supplement means whatever the cost of that healthcare is, it's fully or close to fully covered. This is as close to comprehensive care as you're going to get. You're going to have to get a standalone Part D plan for prescription medications that you get at a pharmacy. And this is going to be the weak link of this particular system. You'll never get a Part D plan as comprehensive as a supplement with Medicare A and B. If you're lucky, the medications you must receive are done in a doctor's office as an infusion, or in a hospital, or in a clinic. If you're lucky, it's done as part of an inpatient or outpatient process under Part A and Part B. Therefore, Part A covers the initial cost, or Part B covers the initial cost, and the supplement picks up the balance. This is typical for individuals that do things like kidney dialysis, or individuals that go into hospital or a cancer clinic for chemo treatment. It's not part of Part D, it's part of Part A or Part B, and picked up in total by the supplement. But when the prescription medication is self-administered, meaning they go to a pharmacy, pick up the medication, and either inject it themselves or orally take it, it's under this, and it becomes far more cost ineffective to that individual, because the Part D is never going to cover it the way A and B and a supplement would do. In addition, certain things are simply not covered under Medicare A and B. Basic dental, basic eye care, and certainly long-term care, which is considered a personal care circumstance and not medical care, is not going to be covered. Alternatively, if you select option 2, you still have to enroll in Medicare A and B. You cannot have a HMO or PPO Part C product unless you're also enrolled in A and B, but you won't get to use A and B if you have a Part C plan. That is your coverage. The value of this, the value of taking a Part C is the lower premium. Now, A and B are still required. So whatever A and B cost you, that's reflective in either option 1 or option 2. There's no avoiding that. The question is, how much will I save by not getting a supplement or a standalone Part D? How much would those premiums cost that I can reduce instead by getting a Part C? And if I can get a 0 Part C plan, I can save whatever the cost of these two products are. So if this is $150 and this is another $10, so $160, by getting a very cheap Advantage plan, I can save myself $160 a month. And maybe that's important. Now I have to accept the fact that I'm not going to get as comprehensive coverage with any Part C as I would with A and B and a supplement, and maybe that's okay. Maybe I don't want that kind of comprehensive coverage, or at least need that kind of comprehensive coverage. I'm really healthy. And I even though I could afford $150 or $160 more a month, why would I want to pay it when I'm really not going to use it? And yeah, I know down the road I could get really, really sick, but that's down the road, and that's not my priority. That's okay. Understand the limitations. Any HMO or PPO product, anyone, no matter how much you pay, even if you pay hundreds of dollars, is going to be less comprehensive than any basic supplement with A and B. In terms of the quality and comprehensiveness of coverage, A and B and a supplement are always going to be more than any Part C plan. You're selecting this limitation for its strong suit, and its strong suit is I pay less in premium. And anyone that spends more in premium to get a Part C than they went on a Medigap is throwing their money away. I'm not dictating you shouldn't get one, but understand why you're getting it. You're getting it to save the premium. And I always feel sorry for the person who says, oh, I got a PPO. And how much you paying for? Oh, it's a good one. It's like $220. You could have had a Medigap for less, and it would have given you more coverage and more reach in the product you're paying more for. Why are you doing that? Because some broker convinced you that by paying more, you're getting more. And all you're doing is just paying more. The one thing, the value it has, and if this is an important value, it's important to you, is the swag that they also offer. We'll cover some dental, we'll cover some eye care, we'll give you health club membership, we'll do all these other things. And some people say, you know what I need more than anything? I need dental coverage. Don't expect much out of it. Maybe a few hundred, maybe even $1,000 worth of, but it's better than nothing. And if I can get it attached to a 0 premium or a really inexpensive, that's what I need. I need someone to take care of my teeth. And all the other stuff can wait. And I know maybe by waiting, I'll never be able to get over here, but I really need all the money I can get towards having my teeth taken care of. That's the most important thing. Okay, I get it. And I know that the dental coverage isn't going to be great. It's not even going to be good, but it's better than none at all. And here, A and B will not cover ordinary dental, and a supplement won't cover ordinary dental. You're going to have to buy a standalone dental plan for another $40 or $50, and I can get that same quality, not great, but I don't have to pay anything additional. And that's what's important to me. I get it. And some people will take an Advantage plan, not for the medical, or for the additional swag. Or I don't even need dental. I just love the idea that I can go to a health club. That's what I use all the time. I get it. As long as you understand that that decision to go with this for that reason may have preemptively precluded you from ever getting something better or significantly better. And that's your choice. And this is the approach that I would take in terms of measuring the quality and comprehensiveness of the product and the decision making. There's not a right or wrong decision as long as you understand what each product does and how it does it, and making your decision based on your immediate priorities. Whatever that decision is, as long as you're entering it with eyes wide open, it's your decision. It's your ownership. Time for questions.
Sorry, Bill, I was muted and I didn't even realize it. That's my fault.
And I was worried,
Uh,
oh God, did I lose the signal? I've been
I'm sitting here reading questions and then I'm realizing that I'm reading them to myself.
I'm so
Um,
glad it was you, not me.
our first question is if all F or G level Medigaps are the same as an example.
Mm-hmm.
Um, and you did kind of cover how companies provide different prices, but is it like the private insurance with sort of in and out of network coverage where I think and I apologize to this person, I'm sort of adding to their question, but I think what the question is, really is if they all have to be identical and you eliminate and you showed how they determine where the prices go up, how can some of those companies still have different pricing?
Again, the prices aren't that different. Um, most of the reputable companies that are selling F levels are clustered around the same price amount. It's through their discounts that they're competing. Uh, so basically, I'll give you an example. A person entering Medicare, and to make it an F level, let me make it a G level to make it easier. A person that's just turning 65. So they're certainly born after 1954. They can't get the F level. They can get a G level. And the G, like the F, is identical. Whatever company's selling a G level, they got to sell the same product in the same comprehensive fashion. So they'll say a person coming in at age 65, we're going to offer the product. Aetna says, I'm going to offer it at retail $140. And Cigna says, we're going to offer it for $142. And United says 147. It's like they're going to be within dollars, not even tens of dollars of one another. There's outliers. Highmark always, I say it this way, they think their shit doesn't stink and they're going to offer 170 or 108. Why? Because we're Highmark. You guys may remember this. Why get Sony? Because Sony, no baloney. It's like the brand carries with it a certain sense of we're better, but they're not. A reputable company, a company that's going to do what a Medigap is supposed to do, pay the balance that Medicare A&D doesn't pick up and pay it in a timely way. That's their job. And they're going to be exactly the same. And most companies that understand this and do not purport to think, oh, you must want us because we are who we are, they tend to be pretty competitive with one another. The value difference often is in the discount, as in, if your spouse also buys from us, doesn't have to be even the same product, but buys a product from us, we'll knock it off by 10 or 15% for both. Wow. If you purchase and you happen to be a non-smoker, as in just a desire to get non-smokers rather than smokers, we'll knock off 5 or 10 or 15%. So the variance, the significant variance, really is in the discounting. And this is why individuals need to be aggressive in shopping, not just, oh, what's your premium, but also what kind of deal are you going to give me at this point in time? So in terms of why would the premiums vary, they don't. They really hardly vary at all. And with companies that are reputable, why do I keep saying reputable? There's probably hundreds of companies out there selling supplemental products. A lot of them will try to undersell and stay away. Oh my God, I can do this for 80 or 90. There is a reason. You got this product and now you're waiting for it to do its job. And your doctor says, I haven't gotten that balance from Ishkabibbles Insurance Emporium yet. And now it's been 6 months. And honestly, if I'm going to see you again, if we're going to do a service again, either you pay the balance or get them to pay me the balance, or we don't take care of this problem until it's resolved. Some companies are not good at doing their fundamental job of paying the balance that A and B doesn't pick up in a reasonable time. Why? Because they're not a very good company with a good infrastructure. And what they save in not having an effective infrastructure, they try to pass on in terms of selling volume of product. Stick with about a half dozen to a dozen knowable, reputable, reasonable companies that have legs, that'll be around, that do their job. And what you'll find is pretty much all of them are within a few dollars of range based on each product. Next question.
Okay. I'm going to skip a couple of questions and come back to them just because there's a question here that sort of follows up to this. So, in comparing a Medigap coverage to a Medicare Advantage plan, do the Medicare Advantage plans give you coverage for more things?
Well, if by more things you mean the extraneous stuff like health club memberships and dental and eye care, yeah, things that are outside the normal Medicare umbrella. That's their selling point. They're not giving you comprehensive dental or comprehensive eye care or comprehensive anything. They're giving you a little taste of it. We'll pay for dental up to $500 total for the year, or dental for $1,000 for the whole year. That could be one service, one high, complex, expensive service. And well, that's what you get. But a person will say, no, that's $1,000 that I would have had to have paid in addition if I went with another kind of coverage. So yeah, I'll take it. So they're going to offer a varying array of things. And to some degree, it becomes overwhelming. Oh my God, look at all this stuff. And how do I compare all of this stuff at the degrees to which it covers to all of the stuff that another Advantage plan is? And there's a certain intent in that. By overwhelming you, by just feeding you all of this poop of detail, you're inclined to say, I can't make a decision. Won't somebody please help me? You're more than happy to. So be careful. Don't go in looking for all the things. Start by saying, what do I want and need? All of the things are irrelevant if you're not going to use them. What do I want now? What do I expect as down the road? And how much am I prepared to pay for that? Is just one approach. So in terms of volume of things, an Advantage plan will offer you all sorts of other junk, which to some people isn't junk. But what a Medigap does is say, look, we are going to cover in total, or mostly in total, whatever Medicare A and B covers but doesn't cover completely. If there's a 20% cost share, we got it. If there is a dollar amount that Medicare A and B won't pick up, we got it. What about the extraneous other stuff? We don't do. It has to be in the Medicare lane for us to cover it, but we do a good job at that. We don't do a lot, but what we do is really good. And you have to decide, is that core thing, the access to inpatient care in a hospital, or the outpatient services of seeing a doctor, getting outpatient therapies, getting outpatient diagnostics, the core of what I want? If what you want is health club memberships and dental and eye care and that kind of stuff, if you really need hearing aids right now, you may say, but Medicare and Medigaps don't do that, and I need that now. All right, I get it. And the immediate gratification of getting those things and the economic value of that may be important enough that you give up on a guaranteed higher level of coverage down the road and accessing doctors and healthcare providers anywhere, and never worrying about down the road, oh, what if Highmark and UPMC go to war again? It's up to you what you value at the time and how you execute on that. Next question.
I think this one also follows up pretty well. So, just for clarification, you when you choose a path, if you choose to go to Medigap or you choose to go to Medicare, the Part C coverage, once you've made a choice, you're committed to that, or can you change at some point? And if you can change, is there some sort of a penalty for doing that?
Well, it's not a penalty. It's simply you're denied. So here, you're at the beginning of your entry into Medicare. You can go this way or that way. If you go this way, I'm going to get me a supplement, a Medigap. Can I give it up? Sure, whenever you want to. Can I get another Medigap? Not unless you're prepared to go through underwriting. Can I go over there? Yep. And they'll embrace you and say, hey, welcome over here. We're going to make us $1,500 a month off that decision. Can I go from here to here? Same no. Unless you can pass through underwriting, unless you have a triggering event, you cannot go from option 2 to option 1. So it's very single lane. You can give up a Medigap. You can jump over to an Advantage plan, but likely that's the jump you're going to make for the rest of your life. Because here's what's going to happen. Why am I leaving a Medigap? I don't want to spend the money. I mean, I know it's got quality, but I don't want to spend the money. Or there's something else I want more than comprehensive coverage. I want that dental. I want that eye care. So playing the game of, oh, I'm going to use this to get the dental taken care of. And then I'm going to go over and try to get a gap. Maybe you can pull it off. Maybe you can get all your dental work done in a couple years and jump over to a gap, and maybe they'll take you. You better hope you stay healthy. And you better hope that when you go to the company that says, yeah, we'll put you through underwriting. I know, yeah, you've made it through underwriting. Oh, and by the way, you know that 140? Oh, those were the days when you were 65. But I'm still healthy. I know, but you had to go through underwriting to get back. Now it's 250. Whoa, it's like because you went through underwriting. It's like we call the shots. You don't want to stick with your Advantage plan. Statistics are people that go with Advantage plans initially stay with them. They stay with them for all sorts of reasons. They'll get lulled into, I love not paying a premium. I love getting this other kind of swag. Or I keep putting it off and putting it off. Get one more year's worth of mileage till the cancer diagnosis, till the major surgery, till they, sorry about that. You are now on record as being uninsurable in an underwriting process. Hope you like your product. Well, you can swap from one Advantage plan to another, but you ain't going to go to a Medigap ever again. Sorry about that. So, yeah, you might pull it off, going from here to there. Don't count on it. And you can certainly give up option 1 and go over to an Advantage plan. They'd love to have you. But don't purport, even if you're in option 1, to be able to flip from one Medigap to another, even with the same company. You have to go through underwriting, and you may not like the result, even if you downsize, even if you change within the same company to a different product. The price difference could be significant. You want to pick a gap initially, stay loyal to it, and the company. That means you're making a hard, long choice, not only about the level of Medigap coverage, but the company you're doing it with. You're going to have to do some hard shopping. Next question.
All right. Medicare Part A and B cover durable medical equipment. If you go with a Medicare Advantage plan, does that mean that only Medicare Advantage plan will cover the durable medical equipment?
You betcha. That means you also have to go to the provider that Advantage plan says this is who we work with, or providers. And you have to be at the mercy of that Advantage plan saying, nah, you're not going to get another wheelchair. Nah, you're not going to get another bed. No, we don't think you need it. By the way, that doesn't mean Medicare is going to be a sweetheart about it either. But statistically, again, it is harder to get equipment through an Advantage plan that you think you absolutely need, that the doctor says you really should have. The whole point of an Advantage plan, it is pure private insurance. It is pure driven by, wait a minute, we're getting $1,500 as a subsidy. That's what we get, and whatever we collect in premium. We are driven to make a profit. That's the whole point of why we exist. Unlike the government, which says, ideally we want to break even. Whatever we get in our budget, we want to spend that. And ideally, we don't want to go back to the payers of it, Congress, and say, oh, we couldn't stay within our budget. If a private company says, hey, you know what, we just broke even this year, somebody's head's going to roll. What they want is show us the biggest profit you can make. And so there is an incentive to say, how much do we get? Well, we get $1,500 and whatever we collect in premium. And how much did we spend? As little as we have to on coverage. And the less you spend, the less we allow you to spend on our money, the more we retain of that $1,500 in premium. You're buying into, you're embracing a system which basically says the less you use, the better for us, incentivizing them to find ways to minimize your utilization. And one of the easiest ways is simply deny and make you duke it out with them in an appeal process. I spend more time dealing with appeals with private insurance HMOs and PPOs than I ever do with Medicare. It's a whole different paradigm, and it's different in their attitude of coverage. Again, it depends on what you want, what's important. Next question.
Okay. Why, when you go for medical care and vaccinations, do they always ask for your Medicare card first and then want your private insurance card?
Because sometimes there are some situations, because it is politically expedient for certain things to be done by Medicare. And they will say to private insurance companies, look, we're going to insist people, we're going to incentivize people. This is one of those rare times, we'll take care of it. Don't worry about it. Put it on our tab because we want to get everybody vaccinated. So you know what? We'll pay for it. Private insurance company, you're off the hook. And the private insurance company, thank you very much. So on some rare occasions, either under Part A or Part B, the government will say, show us your card, we'll take care of it. It's not going to be on the private insurance company's nickel. Do not expect that very often. It is things like, we want everybody to get the COVID vax. Don't worry, we'll take care of it. There's got to be a political motivation for this. Other than that, the burden's on the private insurance. And that is why often when you go, sometimes they ask just because they just do. They don't necessarily have to ask. And even if they say, well, the government makes me, no, the government doesn't make you. The government's making you ask for insurance coverage and not necessarily A and B. And it's the store policy that's simply driven in that case. Some rare times it is because Medicare A or B will pick up the cost, but those are politically carved out. Most of the time, it's simply an overzealous store manager imposing, I want to see every card this person has, regardless of whether we're going to use it or not. So sometimes it's important, sometimes it's irrelevant. Next question.
Okay. As of now, this will be the last question, unless I receive one while you're answering this.
Okay.
So the question is, in the Medigap chart that you showed earlier, there was a listing for skilled nursing care and I believe hospice care.
Let me get back to it. Hold on. Oops, there we go.
So in terms of possibly needing a nursing home or something along those lines, is Medigap or a Medicare Advantage plan a better option? Do either one of them fully cover any kind of long-term care, or are they pretty much the same?
Well, here's the way to interpret hospice care coinsurance to start with. First of all, the hospice coinsurance is minimal. If you are within hospice care mode, you'll notice pretty much you're kind of, the screen is kind of blocking me looking at this. Let's see if I can move you guys out of the way. You'll notice with hospice care coinsurance, right across the board, they're hitting it. But here's the misnomer about that. Hospice care under Part A of the Medicare system is pretty comprehensive unto itself. We're talking about literally a few dollars for the additional co-insurance. And that usually is co-insurance for certain medications or certain kinds of equipment. By and large, under hospice, 90 something percent is covered purely under the Part A. So you're not really getting much in the way, but it doesn't matter because any level of Medigap is going to do it. I think what you're more concerned about is skilled nursing. And here's where C, D, F, G, M, N are going to do better than A and B. But here's the problem with skilled nursing. You think by skilled nursing, oh, you're going to cover it indefinitely as long as I'm in skilled nursing. No way. Remember, this is the handmaiden of Medicare A and B. They will cover it up to the point that Medicare A and B covers, and they pick up the balance. When Medicare A, this skilled nursing is under Medicare A of the system, says that's it, we reached our limit, not in terms of dollars, but in actual coverage. We will cover, says Medicare, says Part A, we will cover your being in a skilled nursing facility for up to 100 days. After that, it ain't medical anymore. And therefore, we don't cover it. And therefore, the Medigap says, well, if Medicare A doesn't cover it, we don't have to cover either. So yeah, we'll cover the balance that Medicare A doesn't pick up of being in a skilled nursing, which could be a significant part, but only up to 100 days. And K said, well, I'll cover 50%, and now we'll cover 70%, 75%, but only until Medicare says, yep, it ain't skilled nursing anymore. And that's really the point. There is an arbitrary line drawn. It's the 100-day line. Prior to 100 days, being in a facility for rehabilitation is considered skilled nursing care. And initially, the first 20 days of that, Medicare A picks up the total amount. The next 80 days, Medicare picks up some of the amount, and this is where your coinsurance kicks in. But after the 100 days are met, that's it. You're not in skilled nursing anymore. I'm still in the same bed. I'm still in the same place, but it's not called skilled nursing. You're not rehabilitating. You're in a personal care mode. Same bed, same place, same everything. New definition. And we, Medicare, don't cover long-term personal care. What does? Your pocketbook does. What about an HMO or PPO? Forget about it. Anything that's called medical insurance, Medicare, Medigap, HMO, PPO, anything private insurance that you buy on your own from a kiosk, your employer group coverage, all of that stuff, if it is health care coverage, draws a line. Before that, being in that facility is skilled nursing, rehab, medical. Cross that line, we're done. And you even wish you could get the 100 days. Often, especially the private insurance companies, in you go to the emergency room, send you upstairs to ICU or send you to a ward, stabilize you. We're sending you out of hospital after a couple days. You're fine. We're sending you to rehab. Rehab, the person's still in a freaking coma. Yeah, I know, but once we get you to rehab, skilled nursing, we can then determine you're not improving. You're not improving. No kidding. The person's in a coma. Yeah, but they're stable. And once we determine you're not improving, you don't get 100 days. You get until we say, gone you are. So the minute you hit a hospital, there is a care management team made up of doctors to some degree, made up of insurance people, and your care manager that has the power to tell the doctor what to do and not do. And they're saying, look, the insurance doesn't want to pay for them staying in hospital any longer. Move them to rehab, move them to skilled nursing. And then the skilled nursing facility says, okay, there's not much more we can do for this person. They should have been in the hospital. Yeah, well, okay, but we got them, and now we can't improve them. So After 3 days in skilled nursing, sorry, they plateaued. Send them home. They can't go home. I'd send them to a nursing home. And will you pay for that? Hell no. That's the whole point of getting them into skilled nursing, to getting them classified as plateauing so we don't have to pay for it anymore. Welcome to the game, guys. And this is more inclined to happen if you're using an Advantage plan. The most aggressive limitation of services in comparison to an HMO or PPO versus Medicare and a Medigap is in the length of stay in hospital and the length of stay in skilled nursing. This is where the huge expense lies. And if the PPO or HMO can get you reclassified into skilled nursing and then reclassified into long-term care, you're off their books. And the cost of literally thousands of dollars a day is avoided. It's a big deal. Then again, you have to be thinking progressively in terms of how do I maximize utilizing inpatient care and skilled nursing care as much as possible. Neither Medicare as your primary care or a private HMO or PPO is a perfect solution. It is our system which dictates trying to shift more and more of the economic burden for longer term care to the patient and the patient's family. And it is economically devastating. More bankruptcies are met because individuals cannot continue the care necessary over a long-term chronic period when private insurance or even the government has abrogated responsibility because they just don't want to spend the money any longer. Welcome to the world. So can I assume that was our last question, or did we get another one?
We did not. So that would be our last question for today. But Bill, I mean, this was incredibly informative as always, and we definitely thank you for your time.
It's been a pleasure. Again, guys, if you think of new questions or want to talk about any of this stuff in more depth, you've got my email address. You've also got, you can visit the website. There's a section on the website for asking questions if you want to do that way. Anyway, either way, hope to see some of you guys at some point in time. And Drew, thank you so much. You've been a great host for this.